Welcome back, everyone. This is a video about treatment of Pseudomonas infection. You need to watch previous videos to get better understanding about the topic if you have not done so before. Therapy for P. aeruginosa pneumonia has been unsatisfactory. Reports suggest mortality rates of 40 to 80%, but how many of these deaths are attributable to underlying disease remains unknown. The drugs of choice for P. aeruginosa pneumonia are similar to those given for bacteremia. A potent anti-pseudomonal beta-lactam drug is the mainstay of therapy. Failure rates were high when aminoglycosides were used as a single agents, possibly because of their poor penetration into the airways and their binding to airway secretions. Thus, a strong case cannot be made for the inclusion of the aminoglycoside component in regimens used against fully susceptible organisms, especially given the evidence that aminoglycosides are not optimally active in the lungs at concentrations normally reached after intravenous administration. Nonetheless, aminoglycosides are commonly used in clinical practice. Some experts suggest the combination of a beta-lactam agent and an anti-pseudomonal fluoroquinol instead when combination therapy is desired. Several beta-lactam antibiotics are effective against Pseudomonas aeruginosa, including meropenem, imipenem, piperacillin, tazobactam, cefepime, ceftazidime, and ceftolozane tazobactam. These drugs are often used as first-line treatments for Pseudomonas infections, particularly in cases of resistance to other antibiotics. Ceftazidime is a third-generation parenterally administered cephalosporin that is usually well tolerated by the patient. The empiric antibiotic choice for hospital-acquired or healthcare-associated pneumonia and ventilator-associated pneumonia needs to consider Pseudomonas aeruginosa, other gram-negative bacilli, and Staphylococcus aureus. Since delayed and inappropriate therapy is associated with high mortality, early and aggressive treatment with early and aggressive de-escalation is an important composite for HOP-AVAP, particularly for VAP management. If possible, hospitals need to regularly generate and disseminate a local antibiogram tailored to their HOP population. Duration of therapy: a 7-day course is generally adequate for both HOP and VAP. A shorter or longer duration can be considered based on clinical response. Hospital-acquired or healthcare-associated pneumonia HOP is pneumonia that occurs 48 hours or more after admission and did not appear to be incubating at the time of admission. Ventilator-associated pneumonia VAP is a type of HOP that develops more than 48 hours after endotracheal intubation. Healthcare-associated pneumonia (HCAP) is no more used currently. HCAP is now classified under CAP, with risk factors MDR pathogens, particularly MRSA and Pseudomonas aeruginosa. Empiric antibiotics for hospital-acquired not VAP with one of the following: septic shock or requiring mechanical ventilation, or received antibiotic in the last 90 is by a combination of 3 antibiotics, plus one of the following: gentamicin 5 to 7 mg per kilogram for every 24 hours, or ciprofloxacin 400 mg kilogram 8 hours, plus vancomycin 15 mg per kilogram every 8 to 12 hours for severe cases, loading dose 25 to 30 mg per kilogram, maximum 3 gram. Remarks: double anti-pseudomonal coverage plus MRSA coverage is important. And antibiotics need to be de-escalated based on culture and sensitivity results if there is clinical improvement. And doses need to be adjusted in patients with impaired renal function, HOP with none of the following: septic shock or requiring mechanical ventilation, or received antibiotic in the last 90 days. A combination of 2 antibiotics, one of the following: ceftazidime to gram intravenous every 8 hours, or meropenem 1 gram intravenous every 8 hours, or imipenem 500 mg intravenous every 6 hours, or piperacillin tazobactam 4.5 gram intravenous every 6 hours, plus vancomycin 15 mg per kilogram intravenous every 8 to 12 hours for severe cases. Loading dose 25 to 30 mg per kilogram, maximum 3 gram. If the proportion of the unit's Staphylococcus aureus isolates thus far has been known to be less than 20%, the vancomycin can be omitted and one of the following can be used. Piperacillin tazobactam 4.5 gram intravenous every 6 hours or cefepime intravenous every 8 hours. Please share the link on Telegram so that many others can subscribe to the channel and watch this videos. Thank you.